Good evening, everyone, and thank you for joining us. My name is Michelle, and I'm a product specialist here at OCULUS. Welcome to tonight's clinical webcast, Dry Eye Disease and the Value of Integrating Modern Diagnostics into Today's Practice with Dr. Kambiz Silani. You have a text box on your GoToWebinar screen where you can enter questions. Enter your questions at any time, and we will discuss them at the end of tonight's webcast. Our speaker tonight is Dr. Kambiz Silani. Dr. Silani is the Chief Clinical Director of Beverly Hills Optometry. Approximately 6 years ago, he proudly started the Advanced Dry Eye Center in Beverly Hills, California. As a second-generation eye care specialist, his high-tech practice focuses on utilizing office-based devices to properly diagnose and treat patients for various ocular conditions, most notably ocular surface disease. In the optometric community, Dr. Silani's modern approach towards the treatment of Meibomian gland deficiency, dry eye disease, ocular rosacea, and blepharitis has made him an influencer, thought leader, consultant, and speaker for a number of tech and eye care companies, including Johnson & Johnson Vision, Visionix, Luminous, Sight Sciences, Oculus, New Sight Medical, Osmotica Pharmaceuticals, Patient Pop, and others. In fact, he was recently featured on the network TV show The Doctors and has written as a guest author for numerous publications and media outlets. I look forward to Dr. Silani's discussion and case reviews. Welcome, Dr. Silani.
Thank you, Michelle. I really appreciate that kind introduction, and it's really a pleasure to be here. Apologize, you guys can't see me. We had some technical issues with the webcam, but promise to make this a really enjoyable presentation and have some really interesting cases to share with you towards the second half. So let's dive right in. So these are a few of my disclosures. Michelle had mentioned some of them. And we were featured and very honored to be invited onto the Doctor Show earlier this year, pre-COVID, to film this segment on MGD, dry eye, and specifically tear care as an office-based treatment for MGD. So just taking the main definition from the TFOS-DUES-2 study, so dry eye is a multifactorial disease of the tear film and ocular surface defined by a loss of homeostasis that results in symptoms of discomfort, visual disturbances, and tear film instability. It's often accompanied by ocular surface inflammation and damage. The way you really want to describe that to patients is essentially that dry eye is one of two things, either the eye not making enough fluid or there's an incorrect consistency of fluid, so the tears evaporate too quickly, leading to various ocular symptoms: burning, watering, grittiness, itchiness, foreign body sensation, fluctuating vision, etc. So this gets a little involved, but I'll simplify it for us. So there's conversation of signs and symptoms. Important to listen to the patient's symptoms, but oftentimes signs may precede symptoms. So having important diagnostic tools to determine and gather baseline data is really critical as far as catching these patients early and getting them the treatment that they deserve, really. So of the 30 or 40 million patients that suffer from dry eye, MGD accounts for about 90% of those patients. So it really is the leading cause of dryness, and that's what we're really going to focus on as we treat patients in the office and as we go through this presentation today. So again, dry eye or ocular surface disease, or MGD, presents in various different ways. So patients may have one or more of the following. So very important to ask them if they're experiencing using a speed questionnaire or other dry eye questionnaire that may have some of these factors, or you can customize your own. But keeping in mind that blurry vision is the most common reason why patients visit an eye care professional or visit our optometrist or ophthalmologist colleagues. So blurry vision, aside from myopia or hyperopia or needing glasses, dry eye becomes the #1 reason for blurry vision. So oftentimes when I'm talking to colleagues as far as starting a dry eye practice, they ask me, well, how do you screen for patients, or where do you look for patients, or how do you market for patients? And oftentimes it's really just the patients in your own practice. So have a deeper conversation with your contact lens wearers. talk to your female patients who are wearing false lashes or wearing cosmetics. Oftentimes, ladies may wear mascara and eyeliner, specifically in the waterline, and that may cause harm to the precious Meibomian glands. Now we're all at home during COVID. A lot of our patients are on webinars, such as Zoom, where they're having meetings or video conferences with their colleagues or clients. So heavy computer use, as we know, it affects the blink rate. Inadequate blinking can cause issues with dry eye and MGD. Look at your patients with medical or skin conditions, your patients with conditions like Sjogren's, arthritis, Crohn's disease, rosacea are all really key patients to look at. Those patients who are on certain medications, such as birth control pills, allergy medications, antidepressants, blood pressure medications, these are also really important patients to screen. So the major contributor causes for dry eye syndrome is, I mean, the list just goes on and it continues to expand, but these are some of the main ones that we look out for. As I mentioned, certain health conditions or medical conditions, medications, your patients who are wearing contact lenses, specifically if they're over-wearing contacts or they're in reusable contacts, patients who are improperly applying or removing makeup, that can be of concern. Also, certain ingredients in makeup can be ocular stressors. So parabens, BAK, which sometimes is in drops, can be in makeup, and that can cause a lot of dissatisfaction to the ocular surface or harm to the ocular surface. Refractive surgery is a big one. We'll discuss refractive surgeries such as LASIK and cataracts in just a moment. Environmental components are really key. So if they're exposed to smoke or low humidity, areas where there's a fair amount of wind, air conditioning, certain pollutants, certain cities, metropolitan cities may have more pollution, although now there is significantly less cars on the road, and our smog layer here in LA has improved significantly. So I don't think that's going to last long though. And then vitamin deficiency and just certain mechanical issues. The patient isn't able to fully blink or completely close their eyes while sleeping in cases such as lagophthalmos. So there's a really great study that was published not too fairly recently, as far as mentioning that patients who use eyeliner on a regular basis may induce tear film instability and actually lead to meibomian gland dysfunction. So the study really looked at a few different key factors. The patients in the eyeliner group versus the placebo group had lower tear breakup time, worsening grading of their MG, meibomian gland anatomy, greater presence of telangiectasia on their eyelid margin, so swollen eyelids, and 4 times greater conjunctival redness or injection. As far as our glaucoma patients, 63% of those patients, there was a study performed where they looked at glaucoma patients, and 63% of those patients had dry eye syndrome. In fact, there are certain categories of medications that can be more toxic to the ocular surface than others. The one that's of key importance are prostaglandins. So a few different studies looked at prostaglandins specifically and how they can contribute to MGD. So those are for your dry patients or MGD patients. You may be a little more selective on which class of glaucoma medications you reach for. The others are listed below. Alpha agonists have a higher incidence of allergies, and beta blockers can affect the lacrimal component. So for our patients that have maybe aqueous deficiency, beta blockers can have an impact there. For our patients who have MGD, prostaglandins have a greater impact there. And for allergy patients, maybe changing class from alpha agonist to one of the others might be beneficial. Specifically, if you come with patients on glaucoma medications that are preservative-free, that would be ideal, or even considering things like SLT or getting patients to see their glaucoma specialist might be beneficial. And that way, we don't have to worry about compliance or are these drops causing long-term harm to the ocular surface. As far as our LASIK and cataract patients, really important to screen these individuals to increase the refractive surgery outcomes. 80% of your patients that you're referring for cataract surgery have some sign or symptom of dryness. So very, very key to screen these patients and to get them treated prior to their surgery. Really straightforward here, 3 layers of the tear film. We have the mucin layer, which is closest to the ocular surface, followed by the aqueous layer, and the most important layer, the oil layer, the lipid layer. Blockages in the Meibomian glands, of course, lead to MGD, which is the leading cause of dry eye. So again, who are we screening? Patients who have systemic or ocular conditions. Keratoconus is one that we haven't mentioned yet. Keratoconic patients are more prone to things like allergies, but also because the eyelids don't move smoothly over the ocular surface because of the cone-shaped cornea, that can lead to lid wiper issues. So these patients may have certain areas where their lid is not contacting the cornea, and that can lead to major symptoms. And actually, I'm one of those patients with keratoconus, dry eye, and allergy. So I got the trifecta there. As we proceed, we have a vast number of ways to evaluate these patients. Now, you can make it as complicated or as comprehensive as possible, or you can simplify your protocol depending on your office flow. So you can hand every patient, really key at our practice, every patient gets a dry eye questionnaire. We specifically, and you can use anyone you choose, but we specifically like the SPEED2 questionnaire. There's also the OSDI questionnaire, the DEQ5 as well, as some others, but those are the main 3. So dry questionnaire, really key, takes about 30 seconds to a minute for the patient to fill out and for the staff to score. Incorporating your fluorescein staining in combination with either lissamine green or rose bengal will be ideal, and to look for any damage to the conjunctival cells, as well as any sort of keratitis or punctate keratitis on the corneal surface. Using digital pressure with a glove in your finger or a Q-tip, as well as a Meibomian gland expressor from Johnson & Johnson, are all really suitable techniques. And then if you want to kind of evolve your dry eye practice or center, bringing in modern diagnostic tools such as tear lab, inflammatory MMP9 testing, things like meibography, non-invasive tear breakup time, lipid layer thickness are great tools as well. If you're going to also check aqueous deficiency, using Schirmer's test is great. Or if you have a Keratograph 5M or a device that can check tear meniscus height, that works really wonderfully to look for tear volume. So step 1, dry questionnaires. So speed questionnaire, SPEED2 specifically, very straightforward. The top half of the questionnaire looks at frequency of certain symptoms. Bottom half looks at the severity of those same symptoms. And really, you can stop there if you like. We typically look for a score of about 6 to 8 or higher. That being said, if you look at the top row there, it says dryness, grittiness, scratchiness. If patients score a 1 on the frequency and a 1 or 2 on the symptoms of dryness, we tend to investigate. That only comes out to be a score of 2 or 3, but we still will proceed. If that score of 6 or 8 is, say, you get 0 at dryness, but you get 1 or 2 at soreness, you get 1 or 2 at burning, watering, and 1 or 2 at eye fatigue, that will prompt us to have a deeper conversation with the patient, and ask them to proceed with a dry evaluation, either same day or have them come back for that workup. OSDI questionnaire looks at a few different components. Feel free to Google OSDI, SPEED, or DEQ5, and you can run through these and see what fits your practice, again, your practice flow best. Here's a DEQ5, eye discomfort, eye dryness, watery eyes. So you can make it as simple or as involved as possible. This is one courtesy of BlephX. Looks at a few other key factors. Some patients may also add that they wake up and their dryness is worse in the morning, or their eyelids feel stuck in the morning. So that's a good addition to your history form, maybe to add that on, or a lifestyle questionnaire. This is a really great one. I believe this was provided by Tear Film Innovations, which was the producer of iLux, now owned by Alcon. This one works really well because it goes over demographic information. As we know, patients who get older develop dry eye. Women are more prone, hormone fluctuations. Those are some other components to keep in mind. Also good to ask patients if they're currently on or have used drops such as pharmaceutical drops such as Restasis, Xiidra, Sequoia, steroid drops. Moving down that list, you can also ask if they're using artificial tears. Really important to find out if you're using preservative-free artificial tears or artificial tears or lubricating drops that come in a bottle. More often than not, 95+% of the time, if you're using a drop in a bottle, that is going to have a preservative. There are a few exceptions. Corneal staining is very powerful. So we have 3 different patients here. The one on the far left was a patient of ours who this is before and after Procarita on the far left. So her tear film was not uniform, very inconsistent. Her vision was fluctuating. And after a few days on Procara, you can see the difference. The middle image, same thing, patient pre-Procara, post-Procara. This was courtesy of one of our colleagues over in Illinois. And on the far right, you can see same patient, right and left eye, prior to any sort of treatment, or their tear breakup time, or their tear film just doesn't look right, doesn't have that really beautiful, uniform, consistent appearance. There's a really interesting case that I just wanted to share. As a lot of patients are ordering contact lenses online, very, 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 very important to maybe send them an email blast urging them to stick with what you've prescribed them, and stay away from these online brands, Hubble being a big one, Waldo, and some of these older generation drops that have really low DK value can cause significant harm to the ocular surface. As you can see, there's a fair amount of keratitis in this patient. 25-year-old who decided he wanted to take advantage of the cute marketing from Hubble. It must have been, I get them often too, where on Instagram you get these little sponsored ads that pop up. And so I think they offer some lenses courtesy to these patients, which I think is a little illegal because they're not being prescribed by an eye care professional. And contact lenses are a medical device. So just a matter of time for our patients to develop significant issues. So I was co-managing this patient with Dr. Asil's office. We put this patient on preservative-free, heavy dose of preservative-free lubricating drops, Alrex, Restasis, Regenerize, which is a placenta-based drop, and Dr. Asil also added on a drop called oculosin. Patient's vision went from 20/40 from initial visit to 20/20, thankfully, after 3 months of back and forth. The patient actually had to go on workers' comp leave because his vision was so affected, and his work is very computer intensive. And of course, we quickly switched him back to Acuvia Oasis One Day, which has a wonderfully high DK, over 100. And we were able to eventually get him off of all his drops. When you're looking at the Meibomian glands, 2 factors we really want to look at is the function or the flow of the oils, as well as the anatomy or structure of the glands. So we're looking at scoring the function. It's on a scale commonly from 0 to 3. This is the one that we use most frequently, and we actually put in descriptions as far as what we're seeing flowing out of the glands. So a score of 0 is very severe. A score of 3 is normal, with 1 being inspissated, more toothpaste-like consistency, so moderate MGD as far as the outflow or lack of outflow of Meibom, and then grade 2 being more mild, diffuse, kind of whitish, grayish hue. We otherwise would call it turbid, and sometimes we can mark that down as opaque fluid as opposed to that clear olive oil consistency. When you're evaluating your patients, the AOA did a really interesting online survey a few years ago. Only 30% of optometrists are routinely expressing these glands. So we're only looking at it 1 out of 3 of our patients. But really, it takes an extra 10 to 30 seconds to check these glands, and that can really help as an early detector for these MGD patients and get them treated. So that way we know that the disease is chronic and progressive, and early detection and intervention can really make a difference for these patients. We have about 4 videos I've included on MGD expression. Here's our first. So you can see that yellow, almost discharge, or that yellow appearance. So this patient is, we would probably call them mild to moderate. That patient would probably be, is more that toothpaste-like appearance, so moderate. The middle video, patient's probably more mild there. And this last patient, that thicker yellowish appearance, we grade that a moderate. When you see the yellow discharge, we also get concerned about possible infectious components as well. So that's really important to keep in mind. Putting these patients on an eyelid cleanser such as Avenova or an OcuSoft product, say Platinum, that has an antibacterial component to it would be really wonderful. Ocular has some great foaming cleansers as well. And maybe even considering certain antibiotic drops or ointments for these patients may be beneficial. Okay, so modern diagnostics. So those are just really simple ways of checking patients without a huge investment. But once you start to get kind of double down on dry eye patients and really start to get excited about taking care of these patients in office, bringing in some of these diagnostic tools can be really beneficial. Oculus has their device that we carry, the Keratograph 5M. J&J has 2 devices, the LipiScan and LipiView. So interesting to look at each of these devices and see what fits best into your practice. We tested a number of different meibographers for an article I wrote for Viva Optometry a few years back, and we decided to move forward with the Keratograph 5M just because it has such a vast number of tools, from just your topography, acts as a great topographer, takes great external photos for patients who may have conjunctival nevus. It takes great fluorescein images, which we saw earlier for dry eye patients, but also for patients who may have a corneal abrasion. And of course, when it comes to dry eye, it looks for conjunctival injection, redness, inflammation, looks for non-invasive tear breakup time, looks at the oil gland and the Meibomian gland anatomy with meibography. It does fluorescein staining again, which works really well for those pre and post treatment patients. The anterior segment photos, especially for the eyelid margin, looking at telangiectasia, lid engorgement, pouting of the Meibomian gland orifices works really nicely. The tear meniscus height option works really well, and recently we started incorporating the lipid layer thickness. So I'll show you some of these as we advance forward. You can also look at their blink rate. So you can put it in video format and then just have the patient take normal blink rates and see what their blink rate is. Do their lids make contact? That's really important because if the lids are not making contact, then the oils within the gland stay stagnant. When the lids do make contact, that's allowing the oils to to move and to be expressed out of the glands and onto the ocular surface. So when you're explaining this to patients, we don't talk about meibography and tear meniscus height and things of that sort. So we try to simplify it for them. So we tell them we're going to do this dry evaluation. It's going to look for your tear volume. It's going to look at the quality and consistency of your tears. It's going to check for any kind of inflammation, bacteria, biofilm, or plaque, most notably for anterior blepharitis, looking at Demodex as well. And we're going to look at the structure and the function of your oil glands, as well as if your lid's closed completely or if you have incomplete eyelid closure. So when we're performing, when our tech performs the crystal tear report, it's looking at a couple of key features. So again, oil gland structure on the upper left there, the volume of your tears, that's the tear meniscus height, in the lower left there. In the middle, that's what an image of the external conjunctival injection looks like, a redness analysis test. Upper left gives us a really great non-invasive tear breakup time photo, where green signifies normal, yellow would be mild evaporative dry eye, orange would be moderate evaporative dry eye, and red would be areas where the tear film is evaporating almost instantly. And of course, we can have them close their eyelids and look for any kind of debris or buildup or Demodex collarettes at the base of the eyelash margin there. And then so the technician goes over performing the test, and then one of the doctors will go over the results with the patient, as well as print or email this crystal tear report. So the crystal tear report makes it very easy for the patient to understand what's going on, look at oil, water, inflammation, and then we can actually put recommendations under each category. So the oil category would be meibomian gland deficiency. The inflammatory category, we would put things like omega-3 supplements and eyelid cleansers, and possibly IPL. Under the water deficiency category, urging the patient to maybe drink more water, 2 to 3 liters a day is what we recommend now. And certain omega-3 supplements. Hydri is a fantastic supplement that helps to support all 3 layers of the tear film. Reesterified triglyceride omega-3s such as PRN work really well to target the oil layer. And on the right there, you can see that it breaks down what each test does, what we're performing essentially. And here's the summary. So for the patient, you can customize exactly what your treatment protocol will be as far as office-based treatments and their at-home therapy or their dry eye kit. Okay, so as far as meibography is concerned, when we looked at the different meibographers, the LipiScan, the LipiView, the Meibox, and the Oculus, we really like the Oculus because it takes the patient's meibography image and it puts it up against a grading scale. So if you look at the image at the top there, you can see that there's a grading scale at the bottom. On the left is grade 0, that's normal. And then moving towards the right, you have mild, moderate, advanced. And that top solo image is actually the patient's meibography image. And you can move that image depending on where you think they fall on the grading scale. So for that patient, you can see there's a bit of meibomian gland dropout and a bit of recession. So we put them in the mild to moderate range. And then if you look at the bottom right, this patient has severe meibomian gland dropout and loss, and they would fall as a grade 3 patient. These patients who have severe meibomian gland loss are very challenging to treat. Therefore, we usually urge patients who are in the mild, moderate phase not to hold off or not to wait. Oftentimes, these changes that we see to the meibomian glands can be permanent and irreversible. There is some evidence, and there are some studies now that are supporting modest improvement or regeneration in meibomian glands using intraductal meibomian gland probing, thermal pulsation techniques such as LipiFlow, and IPL. So those 3 treatments specifically may help to regenerate some of these glands. Further research needs to be done in order to confirm these findings. But for the most part, we tell patients that these changes may be permanent, so important to take care of this early and not get to these end stage Meibomian glands. For your reference, if you guys would like to review more information on meibography imaging and our treatment protocol a few years ago, feel free to just Google this, motivate your patients with meibomian gland imaging techniques. I'm writing an updated article for review of optometry that'll include some of our more recent diagnostic and therapeutic techniques. So be on the lookout for that guy as well. All right, so we can see some really great before and after images here. On the far left, you can see that there is a fair amount of debris and buildup on the patient's eyelid margin pre-BlephX and then post-BlephX. BlephX microblepharal exfoliation technique helps to reduce the buildup on the lash line, removes all that buildup, kind of just like a knife cutting through butter. And these images were actually taken with the OCULUS Keratograph. So really great to be able to show patients visually what's going on and how quickly we can remove that and how they can hopefully keep that buildup away with at-home techniques. And then we usually have them come back in about 3 months. And if it's there, we retreat. If it isn't, we congratulate them, and then we push out for maybe another 3 months and reconsider treating at that time. This patient in the middle was very interesting. She came in for chalazion. She was referred over by an oculoplastic surgeon. She had recurrent, the same spot, recurrent chalazion. The surgeon had injected Kenalog or steroids into the affected area. It would go away, but it'd come back shortly after. He referred her to our clinic for this non-surgical, incision-free, injection-free, drug-free approach using IPL. And after about 3 or 4 sessions, you can see that stubborn chalazion has been eliminated. And to the best of our knowledge, it has not returned. We asked the patient to notify us if it did return, so we can see her back for subsequent treatments. But I believe it was pre-COVID that we took these photos. So it's very reassuring. And then, of course, this last patient, significant buildup on the lid margin prior to BlephX and afterwards. And again, the keratograph took wonderful external photos of the eyelids there. GenVis report, there are 2 different we're currently using the Crystal 2 report. Previous to the Crystal 2 report, our software was a GenVis dry report. Not very different, still very easy to read. Just the Crystal 2 report is really nice as far as flow and efficiency from going from one test to another. So we're always looking to shave time off of data collection. And you can see on the lower image there, the patient's meibography. Again, we oftentimes get these patients maybe older or later in the disease process. They've been passed around from office to office. We inherit these patients. We do give them hope, but it's very important for us to set expectations for them. Catching these patients at a mild stage, the expectation of improvement is much higher versus these patients who are very advanced or more end stage. It can be challenging, and we tell them it's more of a marathon and not a sprint as far as getting them to a better baseline. Okay, so with the Crystal 2 report, this specific image looks at the tear meniscus height. Tear meniscus height, we typically want, based off of their grading scale, to be about 0.25 millimeters, 0.26 millimeters or higher. If it gets to be in the 0.4, 0.5 range, and the patient has epiphora, that's usually because the oil layer is evaporating too quickly. So it's not that the tear meniscus height or the volume just has to be over 0.26 or 0.25 millimeters. It should be within a delicate range. So if it's too high, or that reservoir is too deep, then that means that there's some other pathology going on. This patient has the opposite problem, where they're not producing enough tear volume or don't have enough tears. So their tear volume is on the severe side. So once we get the ocular surface really healthy in this patient, we would reduce any kind of inflammatory marker, check for MP9 levels, and examine their eyelid and ocular surface really closely, reduce any components of MGD or obstruction within the glands, and then consider plugging them, as well as have them increase their water intake and use not preservative-free lubricating drops or PFADs. The Keratograph also has a really great feature where you can check the lipid layer as it glides across the surface of the cornea. And so this would be what a normal lipid layer looks like. So watch closely as the patient blinks. There's going to be an upward motion of the tear film. So that slick oil component is just sitting beautifully on the ocular surface there in order to coat the cornea and the eyeball, as well as create a really keen optical surface. This is a really interesting patient who had significant conjunctival redness, inflammation, is a smoker, and we treated her. She decided that she wanted to be treated without pharmaceuticals, and so we treated her with IPL and more of a holistic approach. And so you'll see left is the before and right is the after. This is kind of 9 months after being on our dry protocol. This is before, back in October. This is after 9 months of drying program. Okay, so as far as diagnostics, we kind of went through dry eye, MGD, what to look for, how to screen, what diagnostics are really key in terms of gathering baseline and also comparative data over time to show that your therapeutic plan is working. And now love to share some really great cases. So I think we have about 12 cases that we'll review, and we'll jump through different office-based tools that we use as far as getting these patients to improve. So this patient came in, speech score was pretty modest, score of 6. When checking the Meibomian glands, they were certainly inspissated, blocked, and we typically check the lower lids as far as gland anatomy and function. Definitely for gland anatomy, we check lower lids, and if there's complete loss or significant atrophy, then we'll check the uppers. As far as gland function, we do actually check all 4 lids. And for this patient specifically, the lower lids, the right lower lid and left lower lid were blocked. Patient had LASIK about 15 years ago and was a daily user of Opcon. So drops like Opcon and Visine and Clear Eyes, we all want to encourage our patients to stay off of these drops. If they need to be on a redness removing drop that isn't, they're going into a meeting or a special occasion and things of that sort, we tell patients they can use Lumify as needed. But this patient came in initially for their visit, speed score 6, and prior to LipiFlow, and then when we saw him back for his LipiFlow follow-up in 6 to 8 weeks post-treatment, his speed score went to a 0. He was ecstatic. His mild dryness, scratchiness, burning, essentially all subsided. So that was great success there. Second patient was also treated with LipiFlow. He is in his mid-30s as well. He has high myopia and significant astigmatism. He's wearing bioaffinity toric XR. Actually, this patient's wearing, yes, he's wearing bioaffinity toric XR. He's had Intacs and spends a fair amount of time on the computer. He also has blepharitis that he's controlled, anterior blepharitis, which he's controlled really nicely with at-home therapy and tea tree oil. I believe we only treated him maybe once or twice in office with BlephX, but compliance really pays off and ends up saving these patients a significant amount of money if they can keep up the routine at home. Some patients prefer not to do these kinds of things at home and would just like to come in more frequently, and we don't object to that. So his initial signs were reduced tear breakup time. He had a mild amount of conjunctival redness, mild changes structurally to his Meibomian glands, and his speed score was quite low. But when we look at his tear breakup time, you can see that he has moderate tear evaporation. Now, it could be that he's not too symptomatic because he's so myopic, he wears his contact lenses throughout the day, that compensates for him, compensates as far as his eyelid not rubbing against the cornea and causing those typical dry symptoms that we'll hear about or see. Nevertheless, when we saw him during treatment, he loved the eye spa experience. And then again, Keratograph has a really wonderful feature where you can look at before and after. So when you look at this image to the right, the LipiFlow image, excuse me, the NICBUT or non-invasive tear breakup time image on the left there was prior to his LipiFlow at the end of October. And then when we had him come back for his follow-up in a few months, you can see that his tear film essentially went from moderate to normal, which is incredible. Keeping in mind that his speed score was only a 2, but we saw that huge improvement in tear breakup time. And that actually correlates, if you look at the grading scale, his tear breakup time went from about 6 to 7 seconds prior to LipiFlow to about 20 seconds post. So you're looking at about a 3-time improvement in his tear evaporative dry eye. This wonderful patient we inherited. She moved from the East Coast. She had a history of LipiFlow, which she actually didn't think was very effective. They had discussed scleral lenses, but she wasn't very fond of putting them in every day. The insertion removal was a little cumbersome for her. She can wear her traditional soft contact lenses for no more than a few hours before developing that awareness. Her dryness became so significant that she stopped wearing makeup. She did use Avenova at home. She did have good sleep. She uses a humidifier in the rooms where she spends the most time with. She was tested for autoimmune conditions, which she was negative. She did have temporary plugs, Blefx, sleep mask, and she's had Xiidra and autologous serum. So she's kind of had it all. She presented with a speed score of 19, just severe dryness, grittiness, irritation, and she felt like the only thing that worked for her was IPL. And she felt that our technique of using the IPL and then doing manual expression after each visit was more effective than her previous provider on the East Coast, who was just doing IPL without expression. So oftentimes that expression combined with IPL can be really helpful. And at the top there, you can see her glands. So she had mild to moderate changes to her gland anatomy. Here's a testimonial actually of her post-IPL treatment, one of her post-IPL treatments.
I came to get IPL because I had really dry eyes that were itchy and irritating me, and I found that I've tried a lot of different things, and IPL has been the only one that's made a difference, at least that I perceive. I've noticed that.
Apologies.
I came to get that getting IPL regularly helps my eyes feel less itchy and generally red and irritated. So a cool gel will be applied to your face should be clean, and a gel will be put all around your face and kind of right by your eyes. And then the procedure itself feels sort of like little tings. It's not at all painful. It's more sort of surprising when it's happening, but I wouldn't say anything it's nothing to be scared of. It's nothing that's going to hurt. It's just unusual because you're not used to having things directly on the eyelid.
Another great patient who presented with initial speed score of 15 after 4 sessions of meibomian flow, able to knock that number down to a 6. Patient presented with irritation, itchiness, and foreign body sensation. We started with his initial 4 sessions of Meibomian, and then I believe about 3 to 6 months later, we did a tear care, and then another 6 months later, he did some research, and he also wanted to try LipiFlow. So we did that just a few weeks ago, and we've seen significant improvement in his signs and symptoms after each of those visits. This video he'll briefly go over how Meibomian felt for him.
The Meibomian treatment over a series of 4 sessions. I noticed an extreme difference before I came in till now. My right eye was much drier than my left. Now I notice it. I'm doing the hot compresses in the evening. More religiously starting the 2nd or 3rd session of Meibomian. And I highly recommend it to anybody that's having dry eye symptoms. It's a game changer.
Okay. As I mentioned earlier, I'm a dry eye. So you guys can't see me on video, but here's a quick photo. I'm a dry eye sufferer as well, and I'm always the first to try these different devices. I'm the guinea pig or patient number 1. I've had experience personally with Lotamax and other steroid eye drops, Restasis, BlephX, and these other office-based treatments. I truly enjoy these thermal modalities. It just feels it's my kind of time to unwind and relax, and really enjoy the experience. With the keratoconus, I had LipiFlow just so I can see from a patient perspective what that feels like. My keratoconus is mild, but I did feel the applicators inside my eye. The tear care or Meibomian systems were nice because the heat is applied externally. And so for that reason, I really enjoyed that. A lot of patients still enjoy LipiFlow, and we get a lot of great feedback and improvement in signs and symptoms. So we definitely see a fair amount of patients who have LipiFlow performed. Zest is an alternative to BlephX, especially during COVID. We tried to push patients kind of in this direction as opposed to BlephX, unless they're really insistent on having BlephX done. Zest is more of a mechanical approach versus BlephX is more of a electronic approach in terms of debriding and cleaning the eyelid margin, removing biofilm, bacteria, and possibly dekeratinizing the eyelid margin or waterline. The Zest treatment is also a bit gentler. Both BlephX and Zest have similar outcomes. Some patients who don't tolerate the BlephX very well do wonderfully with the Zest, especially the formula that they use, the okra-based gel while doing the cleaning, works really nicely as far as gliding the mechanism back and forth along the lid margin externally, and then also along the waterline when their eyes are open. And then we irrigate with pure saline. So moving into Procara, or the amniotic, cryopreserved amniotic membranes. They work really effectively. We had a 75-year-old female patient with dry eye and stromal corneal abrasion. Secondary, so the dry eye, and then also the corneal abrasion. So she kind of had a double whammy there. And so we were continuing to treat the dry eye and MGD, but we really needed to get rid of this corneal abrasion to prevent infection or some other complication. And Procara, very powerful. We've used some of the dehydrated amniotic membranes, not as successfully as a Procara. Procara just has been a slam dunk for so many of our patients. And so we've adapted this technology and really ran with it, especially for these patients who have persistent SPK or punctate keratitis, abrasions, and other ocular surface issues. So after 3 days, this patient's abrasion, I mean, just remarkable improvement there. So 35-year-old Hispanic male with itchy eyelids, eye fatigue, sensitivity to light. Speed score not that high, but you can see that he has significant buildup externally on his lid margin, and patient was treated same day. So you can see the collarettes there at the base of the eyelashes, where the eyelash and eyelid margin meet. When you press on his oil glands, his function was a bit cloudy. The expression was a bit cloudy. So we performed BlephX, and then typically we like to do the eyelid hygiene technique first, and then follow that up immediately with one of the thermal expression techniques. So with this patient, we decided to proceed with the iLux thermal modality. iLux is nice because it does the heat and expression simultaneously, and then we can kind of customize how much heat we want to use, how much and how long we want to apply that heat to a specific area. And that works really well as we visualize the pore meibum being expressed, and we continue on until we see a clear oil expression from the glands. We also sent this patient home with tea tree oil cleanser to use twice a day for 2 weeks, then taper back to once a day, and then until we see them back for their follow-up. Also put the patient on omega-3s and warm compresses as well. BlephX, when the patient came back in 3 months, some of the buildup did return, so we did repeat BlephX at that visit, and then we actually had to put the patient on 1 week course of Maxitrol at their initial visit. So 69-year-old female, a Caucasian female with complex surgical history of cataract surgery, laser for retinal hole, IOL exchange, and pupilloplasty. So this was a referral from the patient's eye surgeon, or refractive surgeon. Patient was historically on Xiidra, refreshed tears, and erythromycin ointment. She had various symptoms from dryness, grittiness, scratchiness, which were the most bothersome, but she also felt burning, irritation, eye fatigue. When we look at the lids in the, you can see the external photo there of the eyelid and superior conjunctiva. You can see that there's some telangiectasia. The lid margin is thickened. The Meibomian gland orifices are also pouting and blocked. And as we apply digital pressure using the Meibomian gland evaluator, you can see just a milky expression from those lids. And then as we look at the different images, you can see the patient, the non-invasive tear breakup time, the fluorescein staining here in the upper image prior to Procara and then after Procara. And then you can also see the tear breakup time. She's got moderate tear breakup, moderate evaporative dry eye. So we treated her with in office with IPL as well as Procara, and that works. The IPL works really nicely to help stimulate the oil glands, reduce inflammation, as well as try to target any kind of bacteria or microbes on the eyelid margin. This is a 37-year-old Caucasian female. Got a few minutes here, and then we'll jump to questions. 37-year-old Caucasian female with history of LASIK about 10 years ago. Chief complaint was fluctuating vision, and you can see that the lower lid, so we have all 4 lids here. We decided to treat the upper lids because the lower lids essentially are nearly 100% atrophied, over 90% atrophied. Thankfully, the upper lids still have a fair amount of anatomy. And what's interesting is that her speed score was a 3. So meibography plays such an important role to catch these patients, whether early or at end stage. The lower lids look like they're end stage. The upper lids still have a lot of potential. And you can have as little as 6 to 8 glands and still score relatively well on the speed score. So it really depends on, it's very patient dependent. And you can see some other findings here, that her non-invasive tear breakup time has reduced, as well as the conjunctival redness or inflammation. So this patient was started on a level up treatment plan, or a 3-step treatment plan of BlephX followed by IPL. So BlephX to manage the lid margin, IPL to reduce the inflammation, and then the LipiFlow in order to clean out the glands, to remove the obstructive MGD. So again, takeaway, important to image lower and upper lids, especially the lower lids are significantly compromised or atrophied. This was the patient that we saw on the doctor show in January. She came back for her second TearCare treatment fairly recently, just last month. So typically, the TearCare patients, one of the great studies that was published, suggested that TearCare patients should be treated 6 months apart. So the results of that study suggested that TearCare can last 6 months. Repeating the second session at the 6 month mark can enhance and prolong the effects of the treatment. This was a 7-year-old patient who has worn eye makeup for decades, including mascara, eyeliner, false lashes, as well as colored contacts. And she has had 8 sessions of IPL, followed immediately by myopexpression, as well as LipiFlow, performed at the 3rd IPL session. She had, at each one of her IPL sessions, when we did myopexpression, her glands just kept expressing. I mean, it was nonstop. So really important, again, to catch these patients at a younger age so we can get them to healthier state. This patient specifically has a history, long-standing history of eye infections. And so having a poor tear film or maybe having obstructive or blocked oil glands leads to decreased tear film. And then within your tear film, you have certain components that can help prevent, can dilute allergens, but also can help to protect you against infections. So that may play a key part in why she develops those eye issues. And with that, I'll pass it over to Michelle. Thank you guys so much for being here and listening in for the last hour. Happy to answer any questions you may have as far as our protocol, what devices you're using, and how we can help you.
Thank you, Dr. Silani. I have a few questions asked by the audience ready for you. Just a reminder, on your GoToWebinar screen, there is a text box where you can enter any questions you may have. If you missed part of the webinar or if there is anything you would like to go back and review, you will receive a link to the recording in the next week. Dr. Silani, our first question is there a certain percentage of Meibomian gland dropout where you tend to notice symptoms starting in patients?
Great question. So it really varies. We've had some patients who have significant anatomical changes and they score very low on the speed questionnaire. And then we've had patients who are on the opposite end of the spectrum where their Meibomian glands don't look relatively normal or may have mild changes and they're extremely symptomatic. So it's very patient dependent, but we always stress the importance, whether I'm speaking to colleagues or patients, to get these patients who either have signs and symptoms treated earlier in the disease process to prevent permanent damage to these precious glands.
Thank you. What Meibomian gland expressor do you use?
We used to use the Ledoux forceps. And then once we signed on with Sight Sciences and picked up the TearCare device, I was a little hesitant to use their expressor, but I'm quite fond of it at the moment. And we've been using that for maybe the last 6 months or so. When you're doing Meibomian gland expression, we oftentimes do it within the slit lamp. There are some colleagues who will do it outside the slit lamp, made with loops. You really have to fine tune the amount of pressure that you apply. So that way you're applying enough pressure to express the glands, but not too much pressure where you may collapse the gland.
All right, thank you. Do you recommend IPL or low light therapy?
IPL works really well to stimulate the glands, reduce inflammation, works fantastically for patients with ocular rosacea. But we've also found that it works well for obstructive MGD patients. So since it's doing more of it's not as effective as your thermal modalities because the heat modalities are providing constant heat at the appropriate temperature for a minimum of 10 to 15 minutes. And then we go into expression. With IPL, it's working really nicely as a flash heat. Almost imagine you're taking a stick of butter and putting it in a frying pan, but lifting it off quickly. So it is melting a bit, but it's not completely melting or solidifying all the meibum. Versus if you're doing, say, iLux, TearCare, or LipiFlow, it's like leaving the butter in the frying pan so it completely liquefies. IPL works really well synergistically with the heat modality, so oftentimes we'll combine those if we see lid abnormalities such as telangiectasia, neovascularization, thickened eyelids, things of that sort. So if we see that in combination with obstructive MGD, we'll combine those two. We typically like to reduce the inflammation first before we unclog the glands, but some patients are very eager and they want to have that heat treatment at their first IPL session. So certainly you can tailor the treatments to the patient's needs.
Thank you. What equipment would be your first purchase when starting a dry eye clinic?
So I'm going to answer that in two ways. So there's first piece of equipment therapeutically, and there's also first piece of equipment diagnostically. So having a meibographer is a really valuable tool in order to gather baseline images of the patient's glands and then be able to compare that down the road. You may even notice, basically at that point, you're just looking for anatomical preservation. You may notice that you're seeing either true or pseudo regeneration of glands. So photo documenting those glands just like you would photo document an optic nerve with OCT or a retina with, like, say, an optos to check for nevus or glaucoma and things of that sort. Imaging the anterior segment with an infrared camera using meibography is really key. So from a diagnostic perspective, the keratograph has been really good for us and has helped as far as our conversions of patients being diagnosed, identifying dry patients, diagnosing patients, and then getting them to treatment. And then on the therapeutic side, having a thermal modality device. TearCare is a very affordable one, and you can make back your ROI within about 10 to 20 patients. And then using a lid hygiene device, such as a manual device such as Zest, or an electronic device such as BluffX, works really well on the therapeutic side. And then you can jump into things like IPL down the road. But initially, having on the diagnostic side, having a meibographer or something like a keratograph works really well to explain things to patients, and so that way they can visualize what's going on. And then on the therapeutic side, a microblepharo exfoliative device like BluffX or Zest, and a thermal device such as portable thermal device such as TearCare.
You mentioned Procara. Have you used any of the dehydrated amniotic membrane? If so, what is your experience? Do they work as well as live tissue?
Yeah, great question again. Procara, by and large, has been a huge hit for us and our patients. Almost slam dunk after slam dunk, as long as the patient can tolerate it and they don't mind being monocular for a certain number of days, typically about 5 days plus or minus. Although Procara now has a newer design called Clear, where it has almost like a pinhole where the patient can see through the center. As far as the dehydrated amniotic membranes, so we're big fans of Procara and the cryopreserve membranes. As far as on the other hand, with the dehydrated, we had a lot of complications early on, as far as the patient not being able to tolerate the dehydrated with the contact lens in place, or the dehydrated membrane slipping out from underneath. That being said, I've heard a significant number of success stories there, but Procara for us has been the gold standard, and for us will continue to be the gold standard unless something changes.
What case will you decide to do Meibo versus LipiFlow versus iLux?
Yeah, so fairly recently, we have moved to, especially during COVID, we're trying to move more to devices that have this. In the past, disposables are kind of negative because of the cost, but during COVID and now that patients are more um, mindful of sterilization, sanitize, and we are as well. We like using devices that have disposables and things that are more automated, so we're not spending as much um, direct patient, we're not directing patient interaction. So LipiFlow and TearCare have become our go-tos for those two reasons. LipiFlow is great because it's fully automated. There are some contraindications and difficulties with LipiFlow. If a patient has smaller eyelid fissures, has keratoconus, is claustrophobic, those can be challenges. But if those aren't problems, then you can move right into inserting the applicators for LipiFlow, and it's fully automated where the heating and the massaging component or the pulsing component is all done there, and the patient is welcome to essentially leave afterwards. And you don't need to have, you can maintain that social distancing. TearCare, similar idea where the first half is automated with the heating component, the second half, the manual expression or clearance component, the patient sitting across from us with the slit lamp and the slit lamp shield, and we become quite efficient as far as our speed in the expression time frame takes, we've got it down to about 3 minutes or so, 3 to 5 minutes, depending on the patient and how quickly they move. Meibomian is more challenging because it requires multiple visits within a short period of time, and you need to have a doctor, technician, or staff member with the patient as you're heating, and then you need to express afterwards. And iLux is also iLux does have disposables, but also you have to be in close proximity to the patient, whereas with iLux, with TearCare expression, you can be across a slit lamp and a shield.
All right, I got a couple questions about IPL. How far apart in time frame do you treat with IPL? Also, have you personally seen previously atrophied meibomian glands rejuvenate after IPL treatments?
So we've had IPL for maybe about 2.5 years now. As we screen patients, we have a very thorough screening process to ensure that there's no potential complications. And knock wood, we've had none, which is remarkable. As far as how many sessions we recommend, typically it's advised do a minimum of 4 sessions, and then we'll extend those treatments if necessary. Treatments are typically spaced out about 4 weeks apart, plus or minus 1 or 2 weeks, depending on the patient and things of that sort. We carry the Luminous M22, which is a 6th generation IPL device. So a lot of the previous generation IPLs may have had complications such as scarring, bruising, long-term redness, pain, where you need to use numbing gel. With the M22, the worst we get or the worst we've seen is a little bit of redness that self-resolves by the time the patient leaves our office. And we have numbing gel in the office, but we've never had to use it. And so we're very pleased with the device. Again, there's this extensive consent form that patients need to fill out, and there are certain relative and absolute contraindications. Darker skin type is a big one that African American individuals cannot be treated because it can cause hypopigmentation. Dark Indian skin complexion is also one that we try to stay away from. So it's called the Skin Fitzpatrick scale, and it's measured from 1 to 6. We typically treat 1 to 4s. For those patients who are good candidates and are able to go through their 4 sessions, they do quite well.
Okay. How often do you find dry eye reoccurs after patients' symptoms have been successfully treated?
So again, that depends on the severity. And so we usually tell patients, depends on the severity and the duration of their condition. So the earlier we catch the disease, the more effective these treatments are. So the less severe their symptoms and the less duration they've had the condition, the better the outcomes are going to be. The longer they've had the condition, the more severe, the more challenging it's going to be, or the more time intensive it's going to be as far as what we do in the office, and then being really diligent about their home routine. Their home routine is really important as far as diet, nutrition, checking to see blood work if they have any food sensitivities, blood work as far as do they have any autoimmune conditions, blood work additionally for any kind of vitamin or mineral deficiencies. Other home routine things that are important are taking their supplements, the compresses, preservative-free artificial tears, lid hygiene, cleansers, maybe humidifiers can be incorporated, drinking plenty of water, healthier, cleaner, maybe Mediterranean type diets. So we go through this extensive list. We talk about different makeup brands that might be more beneficial, or maybe taking a break from makeup. There's a new brand called Eyes Are the Story, which is really promising. So that's one that we started recommending to patients who want to wear makeup on a part-time basis.
All right, we got time for one more question, and they're asking, are these videos, photos on social media account that we can follow?
Absolutely. If you'd like to follow us on Instagram, Beverly Hills, it's at Beverly Hills Optometry. Many of these videos and photos are posted there. And then on our YouTube page as well, Beverly Hills Optometry, you can catch some of those. And then at our website, bhiguy.com.
All right. That's all the time we have for tonight. Thank you for everyone who sent in questions, and thanks for everyone for joining us. Thank you so much, Dr. Silani.
Thank you to the audience. I really appreciate your time, and thank you, Michelle. Really appreciate being here, and look forward to future talks, guys. Stay tuned.
All right. This concludes the presentation, and on behalf of Oculus, good night, everyone.